Today we're going to get started by talking about this patient population that's dealing with multiple chronic conditions and the challenges that they face. Joining me today is a distinguished panel of physicians who have deep experience in this area. Please join me in welcoming Dr. Cynthia Boyd, a professor of medicine at Johns Hopkins University School of Medicine, an interim director in the Division of Geriatric Medicine and Gerontology. Dr. Michael Steinman, a professor of medicine in the Division of Geriatrics at the University of California in San Francisco and the San Francisco VA Medical Center. And Dr. Arlene Bierman, director of the Center for Evidence and Practice Improvement at the Agency for Healthcare Research and Quality, which is part of the Department of U.S. Health and Human Services. Thank you all for being with us. So let's get started with Dr. Boyd, who's going to give us an overview of this patient population, the kind of challenges that they deal with, and the ages and the numbers that we're talking about.
Thank you for having me here today. I'm really happy that you're focusing on this population. And I think one of the first things I would say is that I really like to think about this population as people who are living with multiple chronic conditions, recognizing that living with multiple chronic conditions is just part of who they are and what's important in their life, and that keeping them at the person at the center, I think, is really important as we try to ensure that the healthcare we provide is really what's best for them. So who is the population that we're talking about? So people with multiple chronic conditions in general are defined as having two or more health conditions. So they could be something like diabetes or arthritis, could be something like depression or anxiety at the same time that exist for over a longer period of time. So not an acute cold or something like that. And when we look at numbers in the US, it depends, of course, on what population you're looking at, the age of the group. But about 1/4 of people living in the US have multiple chronic conditions. And even 1 in 15 children do. This is really an issue that increases across the lifespan as we get older. But it is really relevant at all ages as we think about designing the best care. Among older adults, about 2/3 to 3/4 are living with multiple chronic conditions. And one of the things that we see is that for many people, they may actually be living with 5, 6, 7, or 8 chronic conditions, and that this often goes along with a lot of healthcare and a lot of treatments and a lot of medications.
So, Dr. Steinman, let's talk about what people can expect when they are in this category. Is there a situation where people can know that they're at a tipping point, that, a lot of people have something like high blood pressure or depression? Is it something that gradually builds over time, or can you know that you're at risk and that you need to be sort of taking additional steps to try to get yourself out of dealing with multiple chronic conditions that don't ever seem to resolve?
Yeah, it's something that often does build over time. In some cases, if you have a catastrophic event, for example, it can happen fairly suddenly. But for most people, this is the kind of thing that sneaks up on them. And Dr. Boyd mentioned that many people with multiple chronic conditions, it's fairly few in number. For example, you might have high blood pressure and high cholesterol, and that might count as multiple chronic conditions. But for many, though not all people, but many people, that's fairly manageable. The number of medications are manageable. The kinds of things that one needs to do for lifestyle interventions are manageable. But as the number of conditions rises and people's personal situations might change, those two things can conspire to really make these things unmanageable. If you find yourself taking 10 or 12 or 15 medications, or shuttling between 3 or 4 specialists who might be giving you somewhat contradictory information and find yourself confused, those are the kinds of people who I, as a geriatrician, especially worry about, because they're the people both at highest risk of bad health outcomes and also most at risk for having misadventures from their medical care, medications that are inappropriately prescribed, conflicting advice, confusion. And when people find themselves confused or uncertain or thinking, gosh, I'm taking so many medicines and seeing so many specialists, what is going on? That often is a sign that things are awry and we need to do something about it.
Dr. Bierman, can you walk us through what the current status is of caring for this patient population group? Your agency looks specifically at healthcare quality, and this, I would imagine, is a group that is particularly vulnerable when it comes to needing high quality care and perhaps has additional challenges in actually getting what they need.
Yeah, Michelle, you're absolutely right. So, transforming or improving the care of multiple chronic conditions is a priority for AHRQ, or the Agency for Healthcare Research and Quality. And we know right now that our system doesn't often serve many of these people well. It could be fragmented care. They could see multiple specialists or sites and settings of care that are not communicating with each other. They might have complex regimens with high burden. But we know that there's a lot we can do to transform the health system. We have a health system that was built to take care of diseases, and we need to transform to one that takes care of the people living with those diseases, and often multiple, and design plans of care that they can follow and that can optimize their health, and that doesn't place a burden on them, and that's aligned with the context of their lives and their preferences. The other thing I just want to highlight real quickly is that you're absolutely right. We have an epidemic in this country. The prevalence of multiple chronic conditions is growing because many risk factors are the same for multiple different conditions, and we really do have to highlight preventing multiple chronic conditions as well as managing them better.
That's a great point. Maybe Dr. Boyd, you can follow up on that for us. Is there a time when people should be aware, and maybe when doctors should be reaching out to their patients to say, you are at a critical tipping point here, and there are steps that you should maybe take to try to avoid getting into a chronic condition, such as, once you have, more than 2 or 3, is there something that people can do preventatively, or is this pretty much an inexorable progression of disease?
That's a great question, and I think that there's several things that we do already know that can really help. For example, as we think about many of the chronic conditions that might be preventable, thinking about the role of physical activity, regular exercise. I think sometimes we tend to think that that's only beneficial for, say, preventing of heart attacks, but actually we know that physical activity, physical exercise is beneficial for us cognitively. It's actually good for our bones, like the strength of our bones. It helps prevent osteoporosis. So I think many of those things that really do take time and sort of changing our behaviors are effective. Other things are, stopping smoking, eating a healthy and balanced diet. These are all things that we do think actually will end up having impacts on both the likelihood of our getting multiple chronic conditions, but also how easy they are to treat or to manage. I do think that there are things that we also need to be doing as a society as well as healthcare systems that can that I think are really important when we think about prevention at a population level. For example, we know that not having access, for example, to healthy, nutritious food, not having a neighborhood where it's possible to walk safely, where the sidewalks are smooth, and maybe that there's handrails on steps or smooth ways of getting off of them. All of those things are things that I think we need to think as a society how we're addressing not just what is within not just what an individual might be able to do, but how are they actually able to do that in their neighborhood with the resources and supports that are out there in their community and in our society.
I think that's a really important point, that it's not just the health system that's involved here, but also our communities and the way that everybody walks and lives in general and the support that they get. But I do want to look a little bit more deeper into the healthcare system itself. I'm wondering if to what extent there is a specific physician that would be responsible for caring for these patients. I know in a lot of cases, if you're talking about somebody, say, with arthritis or perhaps somebody with Alzheimer's disease, they do have specialized physicians. But who is responsible for kind of coordinating all of the care? And is that well established? Dr. Steinman, maybe you can address that in the way that we are currently dealing with the healthcare system.
Sure. Well, the person who ultimately is, should be responsible and often is responsible for coordinating care is the primary care clinician, which should include a primary care physician, an internist, or a doctor, for example, or a nurse practitioner. Our system is not set up to make that work well. Primary care physicians of all those types are often overwhelmed, have little time. There's little coordination between them and the work of the specialists. And as a result, even though in theory and ideally, primary care physicians like myself should be playing that quarterback function, it can be very hard in practice. And so what we really need to be doing is both on an individual level, working with our physicians, our primary care physicians, to get them the information they need to help make these decisions and resolve these complex care dilemmas, but also create the structures that are actually going to allow primary care physicians to do the job that they're actually trained to do.
Dr. Bierman, this is exactly the area I know that you guys are looking into, raising the bar when it comes to quality of caring for these kind of patients. Can you tell us where we are in that effort? And, is there anything specific that you guys have underway in order to measure this and improve the quality of care across the country?
No, I think that the good news is that there's lots that we could do. I think the COVID pandemic has highlighted the burden of multiple chronic illness in the country and the challenge in getting optimal care. And, it's also highlighted how we need to invest in our public health system as well as our primary care system. And ideally, everybody should have a primary care team within a medical home that helps coordinate their care and supports them. But also we need to rethink how we deliver primary care, in that we need strong linkages between primary care and public health and community services, as well as to specialists and hospitals. And I think the other thing that gives me a lot of hope is that we're growing, just as we have clinical research, we really have the science of care to tell us how to best deliver and organize care in the context of a learning health system. So as we implement strategies to improve care, we can study them and test and learn what works best for which populations, but also learn how to scale and spread effective models of care across the country. If we have time later, I could give you a couple of examples of what ARC is doing in this space.
That sounds great, but Dr. Bierman, you did bring up the whole issue of COVID-19 and coronavirus. So maybe Dr. Steinman, you can tell us how that is affecting your current practice right now, and in terms of how well patients who need to see their doctors maybe quite frequently now all of a sudden have less access because people haven't been going as frequently to their doctors as they were in the past because of concerns about coronavirus. How is that transition happening?
It's a great question, and it's a big mixed bag. There are some benefits to actually the switch over to more telehealth-based options, and it's clear that this is going to be, here with us in the future. For many people with multiple chronic conditions, it can be hard for them to get to see the doctor, either because they have to take off time from work, or maybe if they're old and disabled, actually getting out of the house and going to the doctor's office is a pretty big effort. And so having access where people can contact their clinicians by phone or by video actually eases barriers to access. But on the flip side, there is something really important about being there in person. You can do more, you can create a more important or closer relationship with the patient often, and also provide ancillary services, for example, lab tests or x-rays, or have them see the pharmacist who happens to be right next to you in a multi-specialty clinic. And those things are really irreplaceable in a video context. And so everyone is trying this out and kind of fumbling their way through it. And as we move forward, what's going to be really critical is coming up with ways that we make the best use of telehealth when it works, but also not pretending it can be a substitute for everything. In COVID, we have seen a lot of people delaying care or not coming in for care in a way that they should be, where their uncontrolled chronic medical conditions actually pose a much more greater threat to their health than their risk of getting COVID by going into the doctor's office or the hospital.
Yeah, we've been hearing about that quite a lot, where people are coming into the hospital at a much more advanced stage with their non-COVID related illnesses. Dr. Boyd, can you tell us how it's going at Hopkins? To what extent are you guys implementing these telehealth and other approaches to try to handle these patients with multiple chronic conditions? And do you really think that that is going to be an established part of the approach going forward?
Yeah, I would definitely echo what Dr. Steinman said. I think we're trying out a lot of the same approaches, trying to use telehealth when it really is a good adjunct and delivering the needs someone has, but at the same time recognizing that there are still a lot of things where we need to see someone in person for all the reasons Dr. Steinman mentioned. I do think it's going to continue to be with us, and so I think we already are learning, and I think there's more to learn, and we need to be studying it, like how do we best use it to serve the needs with people with multiple chronic conditions. And I do think a really key thing is that that echoes back to a couple of your earlier questions is that I absolutely think primary care plays like a major role in coordinating and preparing for care of this population, and certainly geriatricians, which I am, and I do primary care in Baltimore, do as well. But I actually think it's really important that the whole healthcare workforce realize that many of the patients they are seeing have multiple chronic conditions, and so that and that even if they are the specialist in one of the diseases, that they really need to be thinking about how that fits into everything someone needs to do or is being asked to do, and like the role that the disease or condition that they're expert in plays in like the whole person, that we all have to be prepared for these patients. And so I think as we think about the role of telehealth and moving forward, trying to provide the best care of the populations, I do think we want to think about how the whole healthcare system can make the most of these tools, but then be maximizing the benefits of being in person when that is bringing what the person needs.
Dr. Bierman, can you talk to us about some of these tools that ARC is, well, not tools that you're rolling out, but some of the surveys and the work that you're doing in terms of determining which approaches are the most effective and making sure that they get out to everyone, as you alluded to earlier?
Yeah, so first I'm going to mention an interesting grant that we're funding in Kaiser Permanente, where they're actually developing algorithms to identify, those people with multiple chronic conditions at highest risk, and then link it to a database of community services to also address the social determinants of health and social risk, and provide that information to the healthcare team in terms of being proactive, and developing it in a way that could be shared across the health system at a later date. So I think using technology to really identify people who have increased needs and to better manage their care and get them the services that they can, I think will make a big difference. We're also working at ARC. We have a partnership with NIH to develop an interoperable electronic care plan. So basically think about an app that the patient can use, all of the patient's doctors can use, as Dr. Boyd was saying, the specialist, the primary care physician, and put in all the information about diagnoses, medications, plans, choices, so that people can really be informed and coordinate and integrate care. And I think, using as technology develops, we'll have better capacity to do these kind of things. And then finally, a big focus of ARC is the integration of behavioral health in primary care. And to think about if you have depression or another mental illness or substance abuse, and then also have things like diabetes, hypertension, cardiovascular disease, unless you get the right care for all of your conditions, your outcomes are going to be worse. And then the ways of aligning behavioral health and primary care is really important for people with multiple chronic conditions as well.
So let's switch a little bit, talking about some of those things that you pointed out, that there are many different areas of intervention that could happen. But I think that with a lot of these patients, especially who have multiple chronic conditions that are impacting the quality of their life, in many cases they have caregivers, spouses or family members, perhaps neighbors or friends, who are kind of bearing a lot of this burden. So, Dr. Steinman, maybe you can talk a little bit about that. To what extent is this situation you're trying to empower the patient, but also making sure that they are getting the appropriate care when perhaps they're not able to mastermind all of their own care if they don't have a really great primary care setup? So the question is, Dr. Steinman, to what extent are caregivers involved in this process?
Caregivers are absolutely essential, regardless of whether or not you have a well-functioning or an ill-functioning primary care system. People who have multiple chronic complex needs that might be compounded by cognitive impairment or functional impairment or other difficulties with kind of taking care of their day-to-day tasks, having caregivers involved is just beyond critical. And if you would imagine for a moment, if all the informal caregivers, spouses, children, friends were to suddenly drop out of the picture, this entire country would fall apart. And so these people are doing heroic work that is typically uncompensated. And we have the supplemental system where there are compensated caregivers, for example, in-home support services or private pay services that can also provide critical, but they're typically not enough. So recognizing the value of caregivers is critical because it helps us focus on what's most important. And supporting caregivers, allowing them to do what they do best and giving them the resources that are going to help them take care of the patients is often the single most important thing, or one of the most important things we can do, because, as a physician, I might see someone in my office for 20 or 30 minutes once every few months. That caregiver is seeing that person every single day or every single week. And they're the person with eyes on. They're the person who's actually going to make the difference in terms of that person's health. And to the extent to which we can support those people, that'll be, is essential and will continue to be essential. And we don't always do a great job with it.
Another area where there is an awful lot of touch on these patients is their insurance providers, because those are the people who are seeing all the bills, so they do kind of know what services these patients are getting. And I know that a lot of them have set up things like, nurse call lines and individual patient support services to help kind of coordinate their care. Dr. Boyd, are you familiar with that process, and do you have any kind of insight or thought on whether or not that's helpful to physicians like yourself, somebody, on the back end of it trying to help coordinate, or does that, get a little bit more in the way, kind of confusing things?
It's a great question, and I think it's honestly one we still have a lot to learn about. Actually, sometimes patients will end up with more than one of those case management or other support systems operating in the background, and so how that all interplays and how does it end up actually being a net benefit is something that I think we do really need to think about. I think that there's actually a lot of literature out there about this, but some of the things that I think are really key about programs like that work well is when they are actually integrated with the care team that is really providing the primary care. So the more that the connections are really made to the primary care clinician in the office, to the specialist, and so that that those are the people in their relationship with the patient and their family that are really driving. I think that's where there's the most value, and I think we really have to make sure that we get the incentives right, that the incentives that are driven by our healthcare system and the insurers are working to make sure that providers really are working together, whether one of those people is actually working for the insurer or whether you're talking about, a primary care physician in the home healthcare agency or a specialist who's in a different health system from the primary care physician. I think one of the fundamental things that insurers can help us do is to make sure that the incentives are driving us towards working together.
So let's talk just for a moment about the idea that we do have these tools, Dr. Bierman, that you were talking about, but what's happening with the numbers? Are we seeing a lot more of these patients with multiple chronic conditions, or are things getting better in the US?
It's getting worse. I call it a syndemic, which means multiple epidemics happening at the same time for all of these chronic diseases for similar reasons. But because of all of the, lifestyle issues, access to care, health disparities, the prevalence of multiple chronic conditions is growing. And that's why we need to do prevention as well as management. And we see, basically I see three groups of people. People of multiple risk factors who we can intervene early before they get the chronic conditions. There's people that Dr. Steinman were talking about who might have a few well-controlled chronic conditions who are doing fine now, but might be at risk in the future. So we want to make sure we optimize their care so they don't develop into complex patients. And those people who are already complex, there's a lot we can do to improve their care and improve their outcomes, reduce duplication of services, or even adverse events that happen because people are not communicating and working cross purposes. So I think it's great that you're highlighting this. I mentioned COVID before. And what we've learned is that people with multiple chronic conditions are at increased risk for COVID, increased risk for bad outcomes, getting admitted to the hospital, or mortality when they get it. So I think there's some urgency for really investing in the research and the care delivery interventions to improve care for this, growing population.
Well, thank you so much to all of you for participating in this panel. That is absolutely a great place for us to stop. Basically, we have the drawback that we have increased numbers here, but also some potential tools and benefits to get a better handle on this going forward.